Neuroswarming is, first of all, discuss the pathophysiology behind it, discuss and understand some of the treatment options and diagnostics, and those recognition skills, of course. Awareness is key. We're going to kind of get into that a little bit further down the slide deck. And then, of course, reflect on how awesome neuro is. So I love to start things off with a little warmth. And so I'm going to kind of talk to you a little bit about Dr. Edward Jenner. Hopefully we all have heard of him at some point in our lives. I was reading actually the Mayo Clinic proceedings, and he made the top 10 most influential people and to have influenced medicine. And because he discovered the cure for smallpox vaccines in 1796 while working at Berkeley. And he was actually quoted to say, "While the vaccine discovery was progressive, the joy that I felt at the prospect before me of being the instrument destined to take away from the world one of the greatest calamities, smallpox, blended with the fond hope of enjoying independence and domestic peace and happiness, was often so excessive that in pursuing my favorite subject among the meadows, I have sometimes found myself in a kind of reverie." I really love that quote by him. And I just want to mention that what we're doing today with neuro, we're really trailblazers. We are creating the path, the future of neuro. Every single person in this room, every person that you're sitting next to, sitting in front of, we're making the path for our future neuro nurses and the healthcare of our patients. And I just want to take a moment to recognize that. So in a way, we're kind of back in 1749 here with Dr. Edward Jenner. A little bit about me. The picture on your left, that is about circa like 15, 16 years ago. That is baby Audrey. I think that was in my anatomy and physiology class, and it was sort of there that I definitely realized that I fell in love with neuroscience. I went originally into cardiology when I did my nursing career, and I did like cardiology a lot, but I ended up falling ultimately in love with neurocritical care. I'm a little bit of a masochist. On the left there, I've got my husband, Gene, our son, Bruce, and that was us recently at Disney. Bruce is, in his own way, a little neuroswarm. He's very excitable, tachycardic, you know, because those peds vital signs, I just don't even understand them. And he's diaphoretic. This was actually this past weekend, we were playing with the hose and mommy got him. So let's talk more about neuroswarming. Where could we see this? So this is going to kind of shock you a little bit, but critical care and intensive units. We can also see it, of course, in the PCU setting and also on med-surg course. And it's due to the onset and duration of neuroswarming. It can onset as early as 24 hours post-injury, and it can last up to weeks, sometimes even months later. So how common is this prevalence? It's relatively common. About 15 to 33% of our comatose patients, individuals who have suffered severe traumatic brain injuries. Now, we don't do a whole lot of trauma at Baptist, but as pop quiz, is a concussion a form of a traumatic brain injury? Yeah, true, yay. I wish I had some chocolate to throw at you. These patients will decline in about 5 to 10% of post-acute care settings. It's associated with worsening outcomes. And it's due to an excessive sympathetic nervous system activity that can develop after severe acquired brain injury. Of course, it's going to be more common in our pediatric and younger population. The tighter that head, right? The tighter the skull, the less room that we have to move. Also, you know, our brain is still kind of, it hasn't really atrophied yet. I was looking at some statistics on that last night and made me really sad. Just due to the birthday that I just hit, which I'm not going to talk about right now. But atrophy can actually start occurring in our brains as early as 40 and starts to really kick in after age 60. Yeah. So what is neurosurgery? Oh, sorry, guys. Can you get a little sound?
It's just so people go.
For those of you that maybe haven't seen this.
No one knows what it means, it's provocative. It's not just so people go.
Right, that's kind of how I felt when I was researching this topic. It is heavily understudied, often goes unrecognized or misdiagnosed. And the real term for it, guys, is paroxysmal sympathetic hyperactivity, or PSH. This is an exaggerated stress response that can lead to poor outcomes and morbidities, and it's due to really intense periods of uncoordinated sympathetic and parasympathetic responses. Paroxysmal sympathetic hyperactivity, or PSH, is a pattern of recurrent bursts of dysregulated sympathetic activity resulting from the severe traumatic brain injury. These episodes are activated, they're sometimes short and in bursts. They can kind of go away. They're very, very dramatic when they do onset, and they can be triggered by stimulation. Although I was looking at a slide deck out of the Trauma Nurses Society last night, and it was like, what triggers it? And at the end it said nothing, question mark, because sometimes it can be, nothing. Sometimes it can be due to an external trigger. So over the years, we have talked about what we call neurostorming kind of colloquially, or PSH is the medical term for it, but we have called it a lot of things over the years. Dysautonomia, sympathetic storming, diencephalic seizures, autonomic dysreflexia. It has had up to 33 names, I think, across medical research and diagnostic articles. So who gets hit? Patients suffering, of course, from TBIs, or traumatic brain injuries, spinal cord injuries, diffuse axonal injuries, or DAIs. It's also associated with greater focal parenchymal lesions on CT imaging, and then of course our encephalitis population. Tumors, specifically gliomas, subarachnoid hemorrhage, but basically any sort of injury that is near or around that midbrain or the central structures of the brain. Quiz time. What part of your brain controls basic functions such as breathing, swallowing, and consciousness? So it's going to be our brainstem. The brainstem kind of consists of 3 parts. I've got a little diagram for you here on your left. I really love that picture, kind of a water spout in between 2 boats. It really made me think of the 2 hemispheres of the brain sort of coming together, and the water spout is our injury, sort of in that deeper midbrain, middle part of our brain. The brainstem is going to consist of our midbrain pons and the medulla oblongata. It is responsible for many functions in life, such as breathing, blood pressure, heart rate control, sleep regulation. 10 of your 12 cranial nerves are along the track of your brainstem. And it serves as a connection between the pons and the diencephalon, which is where we originally kind of thought that neurostorming, or PSH, was sort of coming from. So we're in the area. Clinical presentation, this condition can present dramatically with paroxysmal tachycardia. Again, we sort of have like a waveform analysis. If you're looking at your trends, they will kind of burst up, burst down. Arterial hypertension, bronchial constriction, hyperthermia. This often gets mistaken as a cardiac event due to the persistent tachycardia, which can eventually, if left untreated, lead to cardiac hypertrophy. Dehydration, we oftentimes will have a free water deficit. I know our Weaver 10 peeps are used to hearing that term due to the profuse diaphoresis. So this is a lot of times why we are administering free water. So, anybody in here seen Home Alone? Right, hopefully everyone, if you haven't, you have a little homework tonight, okay? Home Alone is one of my favorite classics. And I don't know why, but this scene really reminds me of kind of what's happening inside our brain when the storm hits. It's sort of like you have an injury. Again, it can onset as early as 24 hours, but up to weeks later. And this is sort of a delayed reaction. Kevin's not here. Kevin's not here. Kevin's not here. I love that part. It's such a like iconic scream too. Like I just want her to come up to me and scream at me like that. But that's sort of what happens to your brain, you know, we have that injury and then along come the synapses and we have an interruption. And then that sort of freak out response, that sympathetic response that puts us into that kind of fight or flight. So the pathophysiology behind this is thought to be caused by an imbalance of the autonomic nervous system. The ANS regulates, of course, vital functions as well. And after a brain injury, the ANS may become overactive, leading to symptoms of the neurostorming. So a lot of times we're going to start to see a catecholamian flood. I really like that picture because we see a lot of flooding here in Florida. But the patient's body is going to enter into a hyperdynamic state, and it leads to an excessive amount of catecholamines just floating around in their body. This results in an uncontrolled dissociation between your sympathetic and your parasympathetic nervous systems. This, of course, can increase morbidity in your hospitalization stay. And then we're also going to, of course, and maybe this will speak to a lot of my Weaver 10 nurses in here, but prolonged states of hypothermia that can lead to a sort of catabolic effect that can lead to a multi-organ system dysfunction. So this is sort of a pretty picture that I found that explains some of the risk factors or some of the injuries that would be associated with the neurostorm. So of course we've got trauma, but we also have hypoxia and hypoxic events, strokes, infections, of course, hydrocephalus, tumors, we kind of talked about that earlier, and then hypoglycemia as well. So basically there is an interruption in your feedback loop. That feedback loop doesn't allow a negative feedback to occur to kind of slow things down. There's no sort of pitfall, if you must, relaxation period. This causes that hyperadrenergic state and outflow and can of course affect all of our organs. Clinical presentation, I put a little pearl for you guys up at the top. I love pearls, by the way. Look for rapid, repetitive fluctuations in their vital signs. So what are examples of our vital signs with neuro? Heart rate, of course, blood pressure. What else? What else? Yeah, and so of course ICP I'd throw in there. So if we're having fluctuations in our ICP in the neuro units, restlessness and agitation. One of our first symptoms that we notice in any almost any neuro condition is especially when the patient is worsening, is a change in their level of consciousness. And so you may see that restlessness and agitation would be a change in level of consciousness. If you were just talking to them a couple minutes ago, they were fine and now they're not, that's a change. Tachycardia is what we're going to do. These cardiac signs are going to be due to that release of the catecholamines in the system. And so we're a little bit late on the response when we're seeing the cardiac involvement. Hypertension, the diaphoresis, hyperthermia, pupillary dilation, of course. We can also see some of that dystonia or that abnormal motor response. A lot of times that gets mistaken for seizures. And so we will treat this sort of like it's just a seizure episode. And we can also see increased tube feed residuals, which is oftentimes why we're asked to check our tube feed residuals in those units because it'll slow down GI motility. All right, pop quiz again. You guys are like, yay. The brain plays a crucial role in controlling the heart. This one's for my cardio nurses in here. Right? Yay, it does. Why does it? And it has to do again with the midbrain, part of the midbrain, but the medulla oblongata, which is arguably my favorite word in medicine. The medulla oblongata is going to be controlling heart rate, blood pressure, and of course digestion. So I have another little fun quick video for you guys.
The medulla oblongata, the medulla oblongata.
That's how I feel sometimes walking around in the other units that don't do neuro. I'm like, the medulla oblongata. So what is dystonia? Dystonia is spontaneous posturing, which can lead to chronic immobility if not treated properly. Physical therapy, occupational therapy, also early recognition, which comes down to nursing assessment. Are we recognizing this dystonic posturing, and are we intervening early? This can lead to kind of sustained muscle contractions, repetitive movements sometimes in the face, limbs, abnormal posturing, of course. And originally this was thought to be seizures that were caused by the diencephalon. So some of the triggers that we're going to see are going to be under sedation, endotracheal sectioning. That's definitely always going to increase the ICP of our patients. Also, they don't like it. I don't think anybody likes having something jammed down their throat and sucked out. So it's going to make them cough, which increases ICP. Anytime we're stimulating them that deeply, that would be a very central stimulus, and that would cause possibly the trigger response. Positioning or repositioning your patients. Pain responses as well. It's hard to tell when they're attended or maybe comatose, but if you can't get a pain assessment from them, that can be a trigger. Noise, I put family on there. I love family, right? But sometimes our families are overstimulating our neuro population. They need to be involved in a part of the care, but maybe we need to pick a buddy and come in pairs and come see the patient and cluster that. Urinary retention is also a trigger, which I thought was interesting because we do oftentimes see neurogenic bladder in our neuro population. So diagnostics, we're sort of lacking a lot of attention and research on this topic. We also just went through COVID, and so I think a lot of research was probably paused during that period as well. There was some going on, but I think it was prioritized. But EEG would show delta waves and theta waves, but there's actually no epileptiform discharges. And so we would put them on EEG, they would be posturing, maybe doing some of this dystonic movement, and we would see no epileptiform discharges. So that's one way of sort of ruling that out. Rapid rises in our ICP that are associated with maybe nothing might be a trigger for you. And then, of course, serum catecholamine levels. This isn't as popular of an option. This can be very expensive and timely. But if you were to get a urine sample on them, their urine would show high levels of epinephrine and norepinephrine. Differential diagnoses. Neuro is a large gray area. And so we oftentimes, see these masks or these kind of stroke doubles or neuro doubles. This will present as neuro worsening oftentimes because we'll see that change or decrease in their level of consciousness. We want to make sure we're ruling out an infection. Of course, seizures if we want to put on EEG. This can also double as thyroid storming, neuroleptic malignant syndrome, and withdrawal. So kind of a lot of masks. We need to definitely be ruling these things out with our assessments and other procedures. Pharmacotherapy, opiate receptor agonists, dopamine agonists, non-selective beta blockers. I'm going to kind of go through each of these classes a little bit. the alpha blockers, the GABA agonists, and also I have read in a couple of articles that they're using a combination therapy of a couple of them. So the two most popular were gabapentin opiates and bromocriptine, and also opiates propranolol specifically and baclofen. And I'll kind of get into that propranolol in just a moment. Have any of you noticed in your neuro settings that we may give propranolol to neuro patients? So we'll kind of talk about that. Opiate receptor agonists, those are going to be like morphine, fentanyl, oxycodone. We need to sort of inhibit that pain response. It also helps sedate the patient. This decreases that hyperdynamic response and controls that cardiac contractility. So it'll actually decrease the hyperdynamic cardiac output. This is when we would want to be putting hemodynamics on a patient. It also decreases the posture episodes. And this is going to be dose dependent. And so each person might respond a little bit differently. Our GABA agonists are going to be things like baclofen, which is going to act on the inhibitory interneurons of the spinal cord. It has been used intrathecally with actually significantly improved symptoms. Gabapentin acts on the alpha-2 calcium channel in the dorsal horn of the spinal cord, and is shown to reduce severity and concomitant medication requirements, which is why it's kind of one of those combo therapies at hospitals that are doing research with this. Our dopaminergic agents, like bromocriptine, have been associated with decreased temperature and sweating, sorry, little typo. Our beta blockers, so B1 cardiac selective drugs are not as effective. Propranolol is the most effective. So a lot of times we'll give like a B1 selective. Propranolol is going to be a little bit more effective in this population because it does cross the blood-brain barrier. It reduces the severity of the episode, and it actually decreases the circulating catecholamine activity, which is going to reduce your cardiac workload and reduce that catabolic drive. Your alpha agonists are going to be things like clonidine. This acts centrally as well as peripherally by reducing the circulating catecholamines as well and kind of reducing that heart rate. This blocks the adrenergic influences of the hypothalamus and ventrolateral medulla. Do we have any questions so far? You guys are like, go back to the music, Audrey. Go back to the music. Neuroswarming is one of those really heavily under-researched topics in neurology. The key to this is going to be our assessment skills, knowing on our PCU and our med-surg floors that we can see this and that they will oftentimes need to go back up to ICU for intervention. But this can happen, you know, kind of throughout the maybe even when things look like they're getting a little bit better. And so early recognition skills, that assessment, the fluctuations in your vital signs, maybe that posturing, and hearing this lecture might help you in the future to be able to identify this a little bit earlier so we can intervene. These are my citations if anybody wants to read some of these articles. There was literally like 10 of them that were recent. So thank you very much. I'm going to hand it over to Ms. Suzanne.
You guys have questions? Yeah, give me 1 second.
Thank you, guys. Great rundown of stuff will refresh my memory. The one thing that is not refreshing very well in my declining brain since I turned 40, 15 years ago.
Sorry,
is
Mr. Bubble.
the relationship between storming and Takotsubo syndrome. Is that something that, because I used to go on to anything actually, but like Takotsubo syndrome, that is usually storming that triggers that as far as the impact of the brain on and releasing catecholamines on the heart.
Yes. So I think that that releasing catecholamine activity can excite any underlying issues or triggers, especially if they have some sort of cardiac dysfunction or problem going Personally, I haven't worked on that in a whole lot, but if there's anybody in the room that wants to comment, feel free. We love a little open discussion in here. Great question, though. Anybody else?
Any other questions? Well, thank you so much.
Okay, a couple of quick announcements. If you signed in as a nurse, please make sure you put your license number on the sign-in sheets. We do need those in order to submit for your continuing education credits, so. If you signed in already, don't know your license number, go back, take a look, make sure it's there, because we can't, and it's legible. I know we all have fantastic handwriting, but please make sure that it's there and it's legible so that we can submit your hours, I think, to CE broker. Also, again, a reminder, your CEU credits are done by day. So on your table, on the text cards on your table, you'll see 3 different QR codes on the back. So if you are planning CEUs for RN licensure, you need to make sure that you scan each individual day separately and make sure you scan the right day, because if you use the wrong day, it will not work. So make sure you scan the correct day. And I think you have questions about that, okay. What else? Gift baskets, don't forget to get your card stamped. I think everybody's been doing that. I saw a lot of you guys hanging out in the red hall. Anything else, Susanna? Anything else I'm missing?
I don't think so. I don't think so. I think to cover it all, I know that a lot of you guys already fill out your evaluation, so even if I do terrible later, or when you already say the next one, so I'm feeling pretty good about this, I think, yes. Just a quick reminder, I can't see who fills out the information, it's actually anonymous, you guys feel the word. But I do sort of count the amount of RNs that are here versus the amount of evals that I got, so that's kind of how I know that you guys submitted the evals, because the person that is us our CEUs to make sure that all of those evals are in there, and so I want to provide her with the information she needs. So if you just, and again, we use the evals maybe so we can continue to improve these for you guys, like that is truly the goal for the evals as well. And then one last thing that I had. And I just forgot it. Don't worry, it's coming back, and I will tell you guys.
Sure. We do have a quick schedule change. Sam is actually going to present after lunch. So we have Dr. Tammy Daniel is here with us. So she's going to give us an indication. We're actually going to lunch early. So you just got to eat your dessert first. Sometime, hopefully you all will stay awake for the remainder of the afternoon. But the good news is we do have a very interactive session to follow lunch along with Sam. So I know you guys, and then we've got some of our rehab folks from both neuropsychology and from Brooks Rehab that are coming, so that'll be a great way to kind of close out the afternoon. So give us just a moment.
Yeah.
Before we return for our regularly scheduled programming. And then we'll have instructions for lunch once that's the end.
I do remember the quick thing. If you guys are not office employees and you do want to get a certificate of attendance for your CEUs, you can come see me and I can get those for you. I can either email them or I can just give you a copy with your name on it for today's day. For the ones that are office employees, normally I submit these to a wonderful person that helps us with it. Her name is Becky. And I will submit it over to her, and then she helps me put it in Cornerstone, and then Cornerstone reports it directly to CU, to CE broker. So hopefully we'll work out pretty well. But if you don't work for Backbase, we can't do that for you guys, so I can give you the certificate.
Okay, thank you, Suzanne. So it's my honor to welcome Dr. Tammy Daniel, who's the Chief Nursing Officer for Baptist Health. We're really excited to have her share with us today, and You know, no pressure, but you're the last person.
Oh, great. It's been a fun day. I started my morning, because we're doing our service awards now for Back to South, as you know. So I started my morning at our freestanding at North, and then I went to Nassau Crossing, and then I went one place, and now I'm here. But this is where I'm gonna be. So can you hear me all right? I'm gonna speak just a minute about what I feel is the most important thing that we can talk about today is gratitude for you as caregivers. And I got to watch that video, the Silas, right? And I thought, who can follow that? But I'm going to talk more about why it's important for you to keep your tank filled and how we do that on a daily basis. So on the screen, we talk a lot about our tagline, a lifetime of health together is our tagline, excuse me. What does that mean? What does that mean to all of you? A lifetime of health together? It's walking alongside people for the long haul, right? Not just on the days that they're in the hospital or the days that they're on our units getting care, our EDs or any of our areas. It's walking them through prevention, treatment, healing, and hope with compassion as one community, as one being, right? As human beings. So as a CNO, sometimes people come to me and they'll ask me, well, what should I be working on? I really want to go in this direction, or I really want to be this. I'm a new nurse, a new therapist. What should I be focused on for my goals for my career? And I try to keep it very simple because we all have goals, right? We all have goals on our quality. We have goals for the health system, but this is personal. And I tell them, I want you to be that care provider that when you walk into a room of a patient or in the ED or in any environment, the family members look at you and say, I'm so glad you're here. I'm gonna go home and rest now because you're here with my loved one. You're here with the person that I love most in the world, and I'm gonna feel comfortable enough to trust you that you're gonna advocate for my family member that I'm gonna go home. What's more precious in our lives and our career than that? For people to leave the things that are most precious in our hands. And I hope that fills your tank every single day, because that's what keeps me wanting to come back and work with all of you, because I feel like we can support you as you're doing that amazing work. Let me tell you a little story where that actually came to life for me. I was at a Daisy and Lotus Award ceremony a few months ago at Back to South. Who's here from South? Yay, our South people. You might remember this. And we were giving out the awards, and I was sharing that comment about what it's like to be a Daisy or a Lotus recipient, the traits and characteristics that you have as an individual. And I talked a little bit about being that person that family members feel comfortable leaving when you're there because they trust you. And after the ceremony, a gentleman and his wife came up to me and they said, my mother-in-law passed away in this facility a few months ago. She ended up moving into hospice care. She was 90 years old, but she was that person that you're describing. In the last 6 months of her life, she was declining in health. And so she was in and out of the hospital fairly regularly. They said that every time she came to Baptist, every time she came into one of your facilities, she was treated with such respect and love. We saw everyone that touched her, loved on her, and cared about her as a person. We slept better at home. We felt comfortable going home because of the care that she was receiving. And I thought that brought that story that I'm telling to life. And he went on to tell me what a marvelous person she was. And he told me a lot of things that she did throughout her life. The one that stuck with me was this was a person that when the Twin Towers fell, when that incident happened, the embassy brought her in to take care of all the children that were orphans. This is a person that had such an impact on people across the world and the time that they needed her the most. That's the kind of character she was. And that's the kind of people you take care of in your facilities every single day. So I wanted to tell you how that story really comes to life. As a nurse, people will change you. Do you agree with that?
Yeah.
They'll change how you look at the world. They'll make you feel more vulnerable yourself. They'll change you because they have courage, because they are humans and they make you feel connected to what you're doing. As you enter a patient's room, think about this. We enter a room as a stranger, right? We don't often know our patients on the first encounters. And within a very short time, we become their advocate, their warrior, and their friend. What other profession has that opportunity? Think about that. People trust us because they know that we will have their best interests at heart. Remember, our patients and families come to us at a time in their lives when they're very scared. They're scared for two reasons. What are they? One, because they know what's wrong and they're fearful of what's going to come ahead. Or two, they don't know what's wrong and what they think the worst, right? And we're that extension to make them feel much more comfortable. Nursing is more than providing care. I like to say this statement. It's really about caring. Think about that. Care or caring. They sound the same, but they're not. What you're learning today and over the next few days is wonderful care, evidence-based care, leading care, research. And that's when our patients come to our facilities. They expect that from all of us, right? They expect that top level care. But it's the caring that you do that really connects with them. That love and support that you show, that caring makes a difference. Let me tell you, those that know me well know I like to tell stories. I think it really relates. One more story before you get to have your lunch. That example came to life again for me. I was talking to another colleague of mine and she was talking about, she was rounding on her campus. And we were talking about caring. And she said, I came up to one of the nurses that just walked out of the patient's room and she said, tell me about your patients. And she said, well, she's here with an abdominal infection. She just had a C-section about 2 weeks ago and she is here. She's gonna have a CAT scan today. And she looked at her and she said, no, tell me about your patient. Did she have a girl or a boy? What's the baby's name? Is she doing all right with her nursing and her breastfeeding? Just told me she just had a baby 2 weeks ago. And she looked at, our nurse looks at her and she said, I don't know, I've been there, you know, she had been there since the day before and took care of her the day prior. She said, it's okay. I'm gonna leave and I'll come back before the end of your shift and I'm gonna ask you about your patients. What do you think happened? She came back, the nurse executive, and asked her about her patients and she knew more of the human connection, and that's what we do. So I'm here really to tell you thank you. As a nurse for 38 years, I know that it's difficult work. It is hard, isn't it? But it's got to fill your tank and be rewarding. And so I'm asking you please to make that human connection. What we saw in that video, when that young man said he had the worst headache he's ever had in his life, and now he's still playing his trumpet, to be able to make that human connection with his family and his sister and his parents, that's what it's all about. And so to me, I just want to say thank you for doing that work. It's miracles. It's miracles. And we couldn't do it without the 5,000 nurses and 15,000 team members that work across our health system. So thank you so much. I want to leave you with this prayer. It's called the caregiver prayer, and I thought it was so fitting for what we're talking about. So please pray with me. Dear Lord, as I care for my patients who come my way, give me strength and wisdom each new day. Let my words be soothing to their weary souls, and God bless me with healing to help them feel whole. Grant me patience and compassion, Lord, I pray, and make your infinite love shine through me in every way. Amen. Thank you for all you do. I appreciate each and every one of you. I hope this is going to be a blessed day and that you learn a lot. I ran into some of you in the lobby and in the restroom, and you said that we're a bit overwhelmed. It's a good thing, right? Because that keeps us on our toes. Thank you, Wendy. Thank you for everyone that put this beautiful conference together. We think a round of applause for you. Please enjoy your lunch. Have a blessed day. Thank you.
Thank you guys. Lunch is here. Thank you, Dr. Dave, as well. You know, the story this morning, which is really, that's what we do with stories. We try to open every year with a patient story and testimony, and it really just is a powerful testament to the work that you all do, the care that you all provide. And, you know, just really a reminder that all of that hard work really is worth it. We don't always see the end result of that, but it's pretty powerful. And I think Silas did a really good job. I'm so excited to see him be able to articulate his future for himself and kind of what he's excited about. He's planning, I don't know if you saw on the video, but he's planning to be a nurse. So really, really excited, you know, that all of the care that our team was able to provide to that young man and to his family. Now he's inspired to kind of, you know, give back to the community in the same way we do. So enjoy your lunch. We're going to be back here at 1 o'clock. It'll be an afternoon full of fun, so don't miss it. If you do have any questions, you need to leave early. Any questions about CEUs, please let us know. And we will see you back at 1.
I got the one that's on too many tabs. Kind of the same thing. All right, what are we doing now?
Yeah, I do fun lunch. Oh, maybe.
I hope so.
Well,
not like.
And then I was like. Sorry. I just walk her down. She didn't need something to work. What's your email? You know.
Yeah, they're going for electronically. My new gig. We went to the nerves meeting actually before that, so which has never been nerves. So I'm no, I'm sure. I'm sure a lot about neurosurgery compensation, I know. And I think for that reason, like I wanted to, because I've done a lot of physician practice management. So. But I know. I'll be out there today.
See when she's back and see if there's. I know.
Friday, yes, I saw that.
Okay, I mean, I know that.
I'll be there, because I asked, Cause I'm not, cause they're like, oh, we're gonna go out and make up, so I said, no, I'm like, we don't know what we're gonna see. So I'm hoping, I'm like, that's great, whatever, I'm like.
Yeah, it's not like, yeah.
Either. I'm excited because, is Rob? She's making she's. You're not gonna be there.
I'm not sure.
Yeah.
I got the whole.